Good afternoon, everyone. Thank you for joining us for our first Heads Up webinar of 2023, Post-COVID Long Hauler Symptoms and Rehabilitation. I am Jana Lemonu, Marketing Manager for Bancroft Neuro Rehab. Two bits of housekeeping before we begin. One, we'll be taking all questions at the end of the presentation. So if you have any questions that you would like to ask, please use the Q&A button at the bottom of your screen. Two, everyone should receive an email with a link to a survey following the webinar. After completing the survey, you'll be able to download your completion certificates and have access to a copy of the slides. All right, well, with all of this out of the way, let's get on to why you logged on today. Joining us this afternoon are two of our passionate clinicians who are practiced out of our Toms River location. They will take us through this timely and ever-evolving topic. Gabby Reposarda is a speech-language pathologist who is highly knowledgeable in cognitive communication disorders resulting from traumatic brain injuries and other neurologic conditions. Dr. Gabrielle Rejo is a physical therapist who has experience working in home health, assisted living, and orthopedics, but her passion is for treating patients with neurologic conditions. So with that, I will now pass this presentation over to Gabby Reposarda. Thank you.
Thank you, Jana. We both have nothing to disclose. Following this presentation, you will be able to describe the symptoms of long COVID, identify key interdisciplinary team members to help optimize patient outcomes, and recognize the typical symptoms associated with post-COVID-19 syndrome, and implement evaluation and treatment approaches. In addition, by reviewing a case study of a patient Gabby and I have treated, we will incorporate the patient's perspective into a service delivery model. Of note, for those who are attending this webinar and not familiar with long COVID, but who are familiar with brain injury, long COVID can be most comparable to post-concussive syndrome. Therefore, you have some point of reference now once we start reviewing the content in the presentation. So what is long COVID? The question of the hour. We know it is a chronic illness that is not fully understood. To date, the World Health Organization defines long COVID as a condition that occurs 3 months after contracting the COVID-19 infection and lasts for about 2 months and cannot be explained by an alternative diagnosis. So these patients recover fully from COVID-19, then 3 months later are experiencing a new onset of symptoms that cannot be explained otherwise. There are some challenges due to the fact that COVID research is still in its infancy stages, such as symptoms vary person to person, strains of the virus differ in symptomatology and severity, prognosis continues to be uncertain, and symptoms don't fully or neatly fit into medical subspecialties. For example, chronic fatigue could be managed by the patient's neurologist, but also by the patient's pulmonologist, et cetera. In terms of expectation versus reality, back during the COVID-19 pandemic, speech-language pathologists expected to be treating dysphagia, dysphonia, and cognitive impairment post-prolonged intubations and complex hospitalizations. However, in reality, the majority of patients with long COVID have never been hospitalized. 100% of dysphonia is secondary to muscle tension dysphonia, and we're primarily treating complaints of brain fog. So here's a long list of reported symptoms for your reference. I will go ahead and highlight the most commonly reported symptoms. Brain fog is a pretty ambiguous term that has been utilized. So let's go ahead and define it. Brain fog is when you're experiencing severe cognitive fatigue and crashes, slowed processing, impaired working memory, making simple mistakes, loss of creativity, trouble focusing, trouble making decisions, lack of initiation of simple tasks, and frequent word finding difficulties. In addition, fatigue that's reported is whole body fatigue despite having proper sleep. Post-exertional malaise is the worsening of symptoms following even minor physical or mental exertion. And this can happen immediately after the activity or up to 72 hours after. It is extremely variable. So one day a person could be fine and the next day they could be toast. Dysautonomia is related to cardiopulmonary issues, and there is a malfunction in the autonomic nervous system. Shortness of breath is a commonly reported symptom, as well as anxiety and depression. The patients report a very heightened level of anxiety. Okay, so what population is being most affected by long COVID? According to a study conducted by Graham et al., there's a female to male ratio, which is 2.3 to 1. This is reminiscent of other autoimmune diseases, such as MS, which is 2 to 1, rheumatoid arthritis, which is 3 to 1, and lupus, which is 7 to 1. Amongst being female, 95% have at least a bachelor's degree, and 70% have a master's degree, PhD, JD, or MD. So these are highly educated women. The average age is 43. According to Graham et al., having a history of anxiety or depression puts you more at risk at developing long COVID. In addition, if the patient's medical history is remarkable for any other medical condition, that condition will now become exacerbated after developing long COVID. In order to have a more holistic approach to treating long COVID as it crosses over different body systems, we utilize a multidisciplinary treatment approach.
So our occupational therapists help people return to activities of daily living. So this is obviously very patient specific. They can provide education on energy conservation and pacing, learning to prioritize different activities throughout the day or schedule rest breaks. Long COVID can have different effects on vision, such as blurry vision, sensitivity to light, eye pain or pressure, and double vision. So these can potentially be addressed with visual therapy. They can address orthopedic issues and strength deficits in the upper extremity and help train coordination with fine motor tasks. They can address impairments in functional cognition alongside our speech therapy colleagues. They're also going to be assessing vitals while performing activities of daily living and asking about symptoms. So do they, for example, have a drop in blood pressure or feel lightheaded when they get out of bed? Does oxygen desaturation occur with standing up and cooking for 30 minutes? So they're going to take rest breaks if this occurs and refer out if needed. Physical therapists are movement specialists. We help improve endurance deficits, strengthen weak muscles, stretch or mobilize in the presence of range of motion deficits, and address pain complaints since patients with long COVID can frequently present with joint pain or muscle pain. Chest pain is also a common complaint in long COVID, and as long as we determine that this is a musculoskeletal complaint and not, we've ruled out cardiopulmonary concerns completely, we can provide education on posture, diaphragmatic breathing, and stretching if appropriate. We assess risk of falls and intervene with balance and education. We can perform dual task training for people who have difficulty performing a cognitive task during functional mobility, such as walking and talking. This becomes an issue when either walking is less automatic for the patient or the cognitive task is less automatic and requires extra brain power, and that can make the person either slower when they move or make them more unsteady. And similar to occupational therapists, we're monitoring vitals and assessing response to exercise, looking for shortness of breath on exertion, orthostatic intolerance, and making sure they have the appropriate changes in blood pressure, heart rate, and oxygen saturation with activity.
The speech language pathologist's role in the patient's recovery is to enable the patient to restore their cognitive linguistic skills as close to their premorbid level as possible, and then to teach compensatory strategies in order to bridge the gap. We will go over the specific strategies later on in this presentation.
We are also going to be working closely with our physician partners. There are long COVID clinics that have physicians in different specialties to help with patients with long COVID who maybe present with different symptoms, which is especially helpful for patients who maybe don't have the energy to drive to different doctors' offices. Patient complaints are variable with long COVID, as we've mentioned, and spread out throughout different systems. So along with what we've already mentioned symptom-wise, patients can report dizziness or vertigo, continued cough or sore throat, burning pain, electric zapping-like sensation, tremors, hallucinations, itchy skin. So long COVID really does span all systems. We're also going to be asking about quality of life and screening for any psychological concerns. PTSD may be somewhat responsible in patients for severe distress and clinically significant impairments in ADLs. There are some overlap in symptoms of long COVID and anxiety, such as palpitations, fatigue, sleeping issues, GI issues, and difficulty concentrating. And we do know that anxiety is a premorbid condition as well as depression. So we should be on the lookout for these symptoms. Patients may not feel comfortable sharing neuropsychiatric symptoms with us initially, and they might also develop them throughout the plan of care. So we should be screening throughout. Recovery for long COVID is very unpredictable. There are no expectations or timeline for recovery. When the onset of long COVID symptoms occur does not correlate, does not predict when they're going to recover. So if it's sooner or later, it doesn't really tell us anything. And also severity of acute COVID symptoms do not correlate with the intensity of post-COVID symptoms. Like we've said, we're seeing a lot of people who weren't hospitalized, who didn't seem to have very severe acute COVID. Symptoms can be episodic, they can fluctuate, and patients can experience relapses where they've gone through a period of recovery, but then their initial symptoms return. So this does make it difficult for us to discuss prognosis with our patients. We do know some factors that are associated with poor prognosis, and those include female sex, higher number of comorbidities, deconditioning, presence of post-exertional symptom exacerbation, autonomic dysfunction, and musculoskeletal pain.
Okay, so the most current ICD-10 code that should be utilized is the U09.9. This should be written on the patient's prescription upon evaluation. This is an important in order for us to submit our evaluations to insurance companies. Okay, so in terms of gathering a case history as our first step in the diagnostic procedure, 2 clinical evaluation tools are utilized in order to promote self-efficacy and resilience, and those are through motivational interviewing and collaborative goal setting. During motivational interviewing, open-ended questions are utilized. So by phrasing a question or a statement into an open-ended manner, you're allowing the patient to take the response in the direction that is important to them. So examples might be, describe your life and routine before your COVID infection, what is going well at home and what is not. We pose these questions because as a clinician, it is important to know at what level was there a change in overall functional status. In addition, listening empathetically and providing empowerment and also providing knowledge is very important because patients with long COVID come to us with a lot of questions. In terms of collaborative goal setting, it's important to set the standard from the initial visit that you are on the same team as the patient. And by providing personalized education, this will foster positive expectations for therapy. As previously stated, these patients are highly educated and can score fairly well on standardized testing. Therefore, it's crucial to supplement standardized testing with informal measures. Oftentimes, standardized testing is not sensitive to the patient's symptoms, and informal measures are able to detect the functional impact these individuals are challenged with day to day and are more reliable when we're reporting their current level of functioning.
So our physical therapists might recognize these as the outcome measures that are recommended by the APTA for people who have had COVID. We have the promise for quality of life that Gabby already had as well. There's the Medical Research Council Sum Score, which is used to measure strength in key muscle groups using manual muscle testing. We have the Short Physical Performance Battery to look at lower extremity functioning as a whole, but we can also take the raw score for gait speed and the 5 times sit to stand test. to give us a little bit more information on specific mobility limitations. They recommend the 2-minute step test for endurance. And they also mentioned the slums for cognition, but if your clinic is interdisciplinary, you can also consult with occupational therapy and speech therapy on cognition. And then I just wanted to mention a couple other measures that can be used. We do have the 2-minute and the 6-minute walk tests that can also tell us about endurance, as well as fatigue, dyspnea, or post-exertional malaise. We have the timed up and go cognitive for dual tasking, which is when they perform functional mobility while performing cognitive tasks, such as counting backwards from 100 by threes, and we assess their speed and quality of movement while they're doing this. Dizziness and balance issues are common. So we have the Berg, the functional gait assessment, among many other balance tests. We have patient-reported fatigue measures, such as the modified fatigue impact scale and the fatigue severity scale. And we use rating scales for pain complaints. Again, joint pain and muscle aches are common in this patient population. I also wanted to mention the DePaul symptom questionnaire for post-exertional malaise. It was designed for myalgic encephalomyelitis or chronic fatigue syndrome. It's used to screen for post-exertional malaise, which, as a reminder, is the increase in symptoms about 12 to 48 hours post-activity. So the screening asks about 5 specific symptoms during or after exercise that would be not proportional to the amount of activity performed. So if they're feeling, say, physically drained or sick after just mild activity. If they have one of these symptoms over 50% of the time at least a moderate severity, this would be considered a positive screen for post-exertional malaise.
Okay, so frequency framework. As the research in this field is still evolving, it is difficult to determine prognosis, as we stated, as well as the duration of services needed. Different from patients with traumatic or acquired brain injuries, the research shows that within the first year of injury, we're seeing the most gains. However, there's no quote unquote window of opportunity for long COVID, as this is variable person to person. What we do know is that our job as the clinician is to restore the skills as close to pre-morbid functioning and to teach compensatory strategies to improve their overall functional independence and engage in daily activities. That being said, we're not recommending years and years of therapy, rather a few months based on what they can tolerate. Something that I like to note, it's important to consider telehealth services for these patients due to chronic fatigue issues, as driving to therapy alone might utilize all their energy for the day, and they may have, several appointments in that particular day. So considering telehealth is something that you should look into. In terms of taking a look at this table, this should serve you as a guide. Please note that not all patients fit nice and neat into these cookie cutter boxes, but if a patient is, highly impaired, like I said, receiving several therapies a week, and suffers from extreme fatigue, we might not be seeing them 3 times a week as they are falling on this chart as being severely impaired. For the speech language pathologists who are on this webinar, the level of impairment and those percentages I am getting from when we enter them into the ASHA NOMS for cognition. So once we get that percentage after entering them into NOMS, I am matching that up in this grid in order to determine their frequency. In terms of intervention, dynamic coaching and metacognitive training and education is the groundwork for our treatment. We want to focus on teaching compensatory strategies for managing both cognitive fatigue and cognitive deficits. So in terms of cognitive fatigue, here is a really nice visual that I share with patients to begin defining cognitive fatigue, as this can be something very arbitrary in nature. So by providing a visual, it has some groundwork to it. The brain on the left is a healthy brain before experiencing a brain injury. Any activity that you and I do, the task will tap into our cognitive, emotional, and physical demands, no matter what it is. As you could see, a healthy brain has plenty of reserved energy there in the orange that we can tap into. That's why we can all go all day long and not really feel so tired. Of course, coffee can help too with that, but you get the point. So the research here is comparing the brain status post a brain injury along with being presenting with long COVID. So we are going, for the purposes of this presentation, the brain on the right, we are going to say is status post having long COVID. And as you can see, this brain on the right has less reserved energy because these individuals require more cognitive, physical, and emotional demands than they needed to beforehand in order to complete those same tasks. Cognitive fatigue is a range of exhaustion resulting from prolonged periods of cognitive activity, and it can last for a few hours up to a few days. Okay, so how are we going to manage this? The spoon theory was developed by Christine Miserandino, who suffered from lupus. The spoon is a metaphor representing energy. So as we learned, patients with long COVID have limited reserved energy. And this theory facilitates their ability to strategically replenish their reserved energy throughout the day. So from the previous slide, picture that healthy brain with all that reserved energy prior to long COVID. They had an infinite number of spoons or an infinite number of energy. The brain after developing long COVID now has a limited number of spoons each day. There's a cap now. The patients in therapy, what we do is we have them list their activities of daily living and then rank each activity depending on how many spoons or how much energy is exerted for that particular task. This is very individualized. The patient identifies, various resting strategies that they can then implement in between these activities in order to replenish their spoons. That way they're not spent by 11 a.m. So an example would be, let's say the patient comes up with this arbitrary number of 10 spoons. They have 10 spoons per day. Then they complete their first task, which might be taking a shower. Then for some patients, this could be a very high energy task, and this might take 5 spoons away from them. So now we have to now implement, okay, what is going to be a resting break after taking a shower? And then that way they can kind of prioritize and plan their day accordingly. That way they can get through most of their, important things that they have to get done, whether it be, therapy, taking care of a family, going food shopping, those types of things. Something to be mindful of is that we want to make sure that their resting breaks are not inadvertently utilizing any energy. So again, like I said, this is very individualized. For some of my patients, taking a shower was actually a resting break. So sometimes they would put that into their, throughout their day. Whereas others, this could be exerting a lot of energy. Some other examples quickly to note of resting breaks could be sitting outside, getting some fresh air, doing a mindfulness activity, doing some deep breathing, actually taking a nap, like physically going to sleep. So again, this is definitely, individualized and varies from patient to patient. Okay, so the relationship between stress and cognition, this is important. Research suggests that there's a strong correlation between stress and cognition. So something to note, when our stress levels are high, cognition is low. We want to implement mindfulness in treatment by utilizing maybe a guided meditation, or some of my patients download the Insight Timer app on their phone, which is customizable to their liking, which can help calm them. I think it's also important to note, to kind of tie it back to that interdisciplinary team approach that we're having, maybe consulting their psychologist or neuropsychologist on further techniques if needed. Okay, so that was a lot of treatment about cognitive fatigue. Here are some strategies that we'll go over to target and manage their cognitive deficits. So our goal, like we mentioned, is to teach compensatory strategies. These are the top 4 domains that we're typically treating, which is executive functioning, memory, attention, and word finding. So speaking on behalf of the speech therapists who are on this webinar, The strategies that are taught for managing executive functioning, such as the Eisenhower box or goal plan do review, as well as like word finding strategies, such as teaching circumlocution. These remain consistent with this population. So your go-tos for teaching executive functioning and word finding strategies still hold true for this population. But I would like to highlight memory and attention specifically based on the current research. So in regards to memory, typically we're teaching both internal and external strategies. However, for patients with long COVID, it's crucial for them to externalize their thoughts as much as possible. So the treatment now shifts and we have a focus on teaching external modalities. These could be things like having them set an alarm, keeping sticky notes around, having lists, keeping a daily journal, having daily check-ins, using a calendar. So anything that's outside of your body that is tangible, you can use as an external modality to help with memory. In regards to attention, multitasking or divided attention is extremely difficult for patients with long COVID. So therefore, two strategies are typically taught. One, can we identify the two tasks that they're trying to do simultaneously? Can we determine, can this be turned into an alternating attention task? Meaning, can one of those tasks be safely and appropriately ignored while the other task is being tended to? So sometimes we kind of take a look and we look at all the tasks that they have for the day, and then I'll have the patient pair up and combined appropriately what can now be turned into an alternating attention task. Or can we pair a task with something that's very familiar or automatic to them? So pairing walking with a new novel cognitive task, something like that. So pairing something familiar or automatic can also help reduce that cognitive load. That way they can essentially be multitasking or dividing their attention. Needless to say, we should be encouraging monotasking as much as possible, building in breaks as much as possible, and utilizing a lot of self-talk, such as, am I on task? What is my job right now? And really having them check in with themselves as even a metacognitive skill.
For physical therapists, there are a few things that we want to consider before we start moving our patients. We're going to provide a systems review for all systems. We know that long COVID affects multiple organs. We're paying particular attention to the cardiopulmonary system, listening for complaints of disproportionate breathlessness, chest pain, palpitations, tachycardia, among others. We're asking about any supplemental oxygen use. Do they smoke? Do they exercise? And we're going into detail on their current symptoms, what triggers them, what makes them better. We're taking vitals before, during, and after activity, screening for exertional oxygen desaturation. So for this population, a drop in 3% for oxygen saturation would be considered significant and would warrant referral. Autonomic dysfunction is prevalent, and I'm going to go a little bit more into that on the next slide. We're screening for post-exertional symptom exacerbation. So we're asking about symptoms and their impact on physical, cognitive, and social activities 12 hours or longer after performing physical activity. If we compare this post-exertional symptom exacerbation to delayed onset muscle soreness, it's different. As PTs, we're okay with and even encouraging a little bit of soreness. We're just making sure we educate on it. Like, yeah, that means you worked hard. For this population, symptom exacerbation after exercise is not what we're going for. We're trying to be very, very cautious. And actually, if we do have symptom exacerbation, we are scaling back. We're going to whatever level we were previously at before we exacerbated symptoms. So similar to post-concussive, we really don't want to push things too much. And then along with the rest of the rehab team, we're providing education on pacing, making sure they have enough rest breaks, and educating on the fact that we are very much trying not to worsen their symptoms during or after exercise. Autonomic dysfunction is prevalent in this population, including orthostatic hypotension or POTS. we're going to pay attention to any complaints of palpitations, lightheadedness, dizziness, fatigue, blurry vision, or presyncope. And we don't want to just, we know these are symptoms of long COVID, and we don't want to just say, well, they're symptoms and we don't need to look further into autonomic dysfunction. We're going to take orthostatic vitals. So we're going to lay the patient in supine for at least 5 minutes, take vitals, get them into standing for at least or up to 10 minutes, screening for an increase in heart rate of 30 beats per minute or higher, which would be considered significant for POTS, and a drop in 20 systolic or 10 diastolic blood pressure in standing, which would be considered significant for orthostatic hypotension and would warrant referral. From a physical therapy perspective, we are providing education on hydration for these patients, maybe starting exercise in supine or recumbent, and then progressing to standing as tolerated. We're performing isometric exercises, recommending compression garments, educating on slow transitions, having them go from supine to sit very slowly, assess symptoms. Are they dizzy? Do we need to lay back down, or can we eventually get to standing? Lots of education, making sure we're, reducing any risk of falls. And then I just mentioned autonomic conditioning therapy. It seems similar to different POTS protocols where it's like a very specific slow progression from supine to standing exercises, really starting with easy supine active range of motion and then progressing from there. And research is still developing on this for patients with long COVID. So return to regular activity is going to be very based on the severity of their symptoms. They should continue all activities of daily living that they were previously able to complete without exacerbating symptoms. In patients with mild fatigue, meaning they can do pretty much all of their household and community activities, but might have difficulty returning to those high intensity things, we're going to progress very slowly. Using the rule of tens as maybe a guideline, so increasing intensity or duration by 10 to 20% every 1 to 2 weeks. But this isn't a set guideline. We're still scaling back in the presence of symptom exacerbation. For patients with moderate fatigue, meaning patients who can do all household activities but are limited in some community activities, such as returning to work, activity will begin at an intensity of 9 to 11 on the Borg RPE scale. And I'm sure some of the physical therapists are saying, what? I never prescribe exercise in that range. It is low. It's lower than we're used to, but we're really taking it easy with these patients. For severe fatigue, we're going even lower. We're starting with upper body and lower body stretching, very light strengthening, again with the supine active range of motion, and we're progressing to aerobic exercise at an RPE of 7 to 9, so extremely light to very light. We're progressing based on symptoms and not any specific timeline. So this slide highlights some of the common symptoms of long COVID, and it correlates them with the potential benefits of exercise. So most of us are aware of the benefits of exercise, especially on the cardiovascular and pulmonary systems. We prescribe exercise to treat musculoskeletal conditions, reverse frailty and deconditioning. Exercise has a positive effect on well-being and helps reduce stress. It can stimulate the immune system, can stimulate neuroplasticity, prevent cognitive decline. But these are for healthy individuals. It's still more important for us to be paying attention to the patient's symptoms and knowing that they can function after they leave the clinic. So this study where I got this image recommended low load, low volume repetitions, because we still prescribe exercise, but we're taking it very easy, not performing reps to failure, making sure exercise is well tolerated, not forcing any sort of progression before they're ready. Okay, so now Gabby and I want to go a little bit into our case study for a patient we shared with our occupational therapy colleague. So this is for a 59-year-old female who contracted COVID in May 2020. She experienced persisting symptoms, including cognitive changes, fatigue, and dizziness. She had a neuropsych evaluation in July of 2021, where she was diagnosed with frontal lobe executive dysfunction, attention weakness, depression, and fatigue. She received her occupational therapy evaluation in September of 2021 and speech and physical therapy evaluations in the end of April in 2022. Her biggest complaints were dizziness after cognitively demanding tasks, as well as dizziness with visual stimulating environments, as well as fatigue and joint pain. She reported difficulty with laundry and other activities where she was required to stand for long periods of time, such as cooking. During her physical therapy evaluation in April, she said that she could tolerate about 15 minutes of activity before she needed to rest. She was unable to participate in her regular leisure activities, such as biking. She had fallen just prior to the physical therapy evaluation while getting off her bike. She's an LPN and she was getting therapy through workman's comp. So from a physical therapy perspective, she performed the 6-minute walk test on evaluation, and she walked about 1,000 feet. For her age range, I would expect her to be more in the 1,600 to 1,800 range. So this indicates endurance deficits. She performed the timed up and go and had a 53% increase from her tug score to her tug cognitive score. So she was a lot slower. We would call this significant for dual task deficits. She completed the activity-specific balanced confidence scale, saying she was about 47% confident in her ability to, say, walk through the mall, get in and out of her car. She was less than 50% confident in her balance. So this is considered a low level of functioning. She required 27 seconds initially to perform the 5 times sit to stand test, indicating lower extremity weakness and power deficits. Her gait speed was just under 1 meter per second, and her functional gait assessment was 18 out of 30. So we would say less than 22 out of 30 would be considered at increased risk for falls. Because she was complaining of dizziness, I did screen for orthostatic intolerance, and that was negative. So I saw her for quite a while. I had her on for 25 weeks for 60 minutes or maybe a little less occasionally for 2 to 3 times a week. We performed aerobic training, strength training, dual task training, dynamic balance, lots of education, and we progressed her based on her symptoms, which were dizziness was her main complaint. So I used just a 1 to 10 scale, how dizzy are you? And we knew that if she was at a 3, then that was too much. That was 3 out of 10 dizziness was we needed to take a break and we needed to scale back the next time. So that was kind of how I based my progression with her.
From a speech therapy perspective, I just like to note during motivational interviewing with her, she expressed concerns primarily regarding her memory, attention and focus, and overall fatigue. She reported things such as, taking a shower and then getting out of the shower and realizing she never rinsed the shampoo out of her hair. She reported it took her several weeks to make a dessert recipe that she's made in the past because she went to and from the store several times because she kept forgetting items. She lost her car in the parking lot several times. While cooking a meal from her family, she got distracted by something going on outside and almost started a fire, which poses a safety risk. Now, as you can see, after reporting all of that, after giving her a standardized measure, I gave her the cognitive linguistic quick test, and she scored within normal limits across all these domains. She's a highly educated LPN. She was able to do these tasks without any difficulties. However, she was noted with some signs and symptoms of neurofatigue after testing. So upon doing that test, we discussed that her performance during this particular test did not reflect her day-to-day difficulties. So then in addition, I gave the neuro quality of life as an informal measure, and the results here speak volumes. Her raw score was 55 out of 140. So she reported things like making simple mistakes, word finding, having to reread something several times, slowed thinking, trouble concentrating, those types of things. We recommended skilled outpatient speech therapy services twice a week for 9 weeks. I think we actually then extended up to 16 weeks, but that was my initial referral for 45 to 60 minutes. We worked on managing her cognitive fatigue, as well as teaching strategies to target memory, attention, word finding, and overall executive functioning skills. Okay. So here is an interview clip of MS upon discharge from speech therapy services, discussing strategies she learned over the course of treatment and which she has found to be most helpful for her.
For speech therapy, what have you feel like has been the best strategies or tips that you've learned that have been helpful for you?
So we've worked on planning and strategies and being mindful and paying attention. So I specifically keep a daily journal, which helps me write out my thoughts or things that happen that I want to discuss the next time I see the therapist. I maintain a daily energy log, and it tracks my things that I've done and my energy level before and after. And then again, we discuss at therapy, and we can see what exercises or what things that I'm doing throughout the day, what require a lot more energy, and then how I should handle planning my day out. So things that take a lot of energy, after that I want to take a break and then do a couple of lower energy activities.
Very good. And I know you mentioned that writing has been a really good tool for you. You felt like that was kind of like the ticket there in terms of like feeling better, like once you were able to get your thoughts down on paper. Can you describe what you used with the sticky notes and how that helped?
Yeah, so I keep little sticky pads throughout my house, because again, I get fleeting thoughts that quickly go away, and so if I have a sticky note and a pen there, when I have one of those moments, I quickly write it down, and then I have it, and I save it to my journal book that I keep, so I can go back and organize everything.
Good. For speech.
All right. So thank you, Gabby, and to our patient MS for sharing her story with us. So in conclusion, we've reviewed the symptoms of post-COVID and the demographics who are most likely to be affected by this condition. Our team shared the benefits of approaching recovery with a well-rounded multidisciplinary team. And from there, our experts explored both theoretically and demonstrated through a case study how they approach treating a patient from evaluation through returning to normal activity. So now that we've been able to kind of go through all of those things that both Gabby and Gabby have brought to our attention, we do have a few questions from the audience that we'll be able to go through. So I will let either one of you guys kind of jump in on these ones. So one we have is, you compared long COVID to other autoimmune disorders. Is overactive immune response being considered a physiological cause of long COVID? If not, what are we attributing this symptoms to?
I can take this one. So short answer, we don't know. There have been different hypotheses, and that includes autoimmune processes, inflammation, organ damage, hypercoagulability, persistent clotting, or persistent viral protein in the body. But these are just hypotheses, and we're not sure yet. So they're still testing for sure.
Big old unknowns right now. Another question we have from the audience is long COVID similar to what polio survivors experience with post-polio syndrome?
Gabby, I don't know if you want to take that one. I'm not too familiar.
I think it's similar. So if the protein is still in the body, basically, like, yes, that's another hypothesis for why people are experiencing long COVID, but we still don't know.
Fair. There was another question about both having access to the slides and specifically the energy pie graphic. Yes, we will have access to the slides once everybody has gotten the survey upon completion. There'll be access to all the slides as well. And that particular graphic was something that we created. So, all right. Another question is: have you seen or found patients with these symptoms that may have become ill, thought they had a severe case of the flu, but were never diagnosed with COVID?
So, Gabs, I can go first here. In my experience so far, I have not encountered that. But according to the World Health Organization, I do know that if they have probable or they never, tested positive necessarily for COVID-19, but it was a prop, like they might have had it and then developed symptoms a few months after, we could safely say that is long COVID.
Yeah, I was gonna say something. Oh, sorry, just something similar. I mean, I haven't seen anyone, but a lot of studies right now are including people who haven't had a positive diagnosis or positive test.
And I think one other thing too, I don't know if this is being brought up or if anybody crossed anybody's mind, because I know what crosses mind sometimes is also determining were these patients vaccinated, their vaccination status. I don't know if that's playing a role in terms of their symptomatology, status post. So it's I know it's a hairy subject sometimes to ask even during case interview, case history intake, were you vaccinated or not? But I think it definitely will play a role in the research.
All right. And would a referral to an ENT specializing in vestibular disorders benefit patients with dizziness?
I would think so.
Yeah, I would say so. I would say yes. In addition, though, vestibular is tricky. My clinical recommendation would probably be to seek out an ENT first, but I wouldn't be surprised if another specialist would need to be, if the patient would need to be to see another specialist as well.
Yeah, and I guess this was something I didn't mention with our with MS. Her vestibular screen was negative. I did an ocular motor screen, and so it wasn't really going to help her. She was having some visual vertigo, which we did some habituation with optokinetic stimulation videos, but I guess it's going to depend on the patient for sure.
All right. And are most long hauler COVID symptoms noted with people who had COVID earlier in the pandemic, and or are you seeing it coming up with more recent COVID cases? So different strains of COVID.
Yes, so we know that the first strand of COVID is the most potent. And for MS, our case study, she was part of that wave. I feel as though now long COVID is being more publicly discussed. So I'm just curious to know that even though there are different strands, are we just more aware of long COVID? And that's why we're starting to detect it more. Something that was noted during the presentation, though, is despite the strand that you contracted and whether you had really severe symptoms or not, this does not now indicate your severity of long COVID. So you could have a very mild case of COVID and fully recover, and a few months later have severe long COVID symptoms.
All right. Next question. Approximately how many patients have either of you seen with long COVID?
I'll go first. I have only had two. Although I know my colleague, I work closely with another speech language pathologist here in Toms River, and she has had, I know of two, if not maybe she's had more. Gabby, I don't know from a PT perspective how many you guys have treated.
I think we've had 4 or 5. One of the interesting things that I'm seeing with my caseload now is I have younger people coming in post-stroke with apparently no comorbidities, and saying that that they had a stroke after COVID. I don't know. They don't know if it's correlated. I don't know if it's correlated. but I do have a couple of people with that as their theory on why they had a stroke. So definitely with some of my younger people, it's interesting and something to consider.
Yeah, I have seen in the research that there has been some type of a correlation between having COVID and now having or being at risk for having a stroke. So yes, it's very interesting and sad.
So next question, either from your personal experiences or from research that you've read, why do you think long COVID affects more educated people versus those with less education?
It's such a good question. I know I've been racking my brain about this one too, and I'm open for feedback. So please feel free to email me, and I would love to chat more about this because I find it super interesting. Gabby, do you have any guesses why it's targeting highly educated women?
It would be a complete guess, but I had thought about the presence of anxiety, which is higher in females. That doesn't really say, like, that's what I was thinking of when I saw your slide, was maybe that anxiety correlation, but I'm really not sure if highly educated women tend to be more anxious. I don't know.
Right. Oh, and then who knows if hormones is playing a role too.
Mm-hmm.
Okay, next question. Have you seen any patients with the diagnosis of long COVID actually fully recover?
Okay, so I'm speaking anecdotally from the 2 patients that I've had. However, in the research, there has been patients that fully recover. However, in my experience here at clinic, I have not seen a full recovery. And it's sometimes we want to define like what full recovery is. Is it, getting back to work? Well, if they're getting back to work, but then now they have learned strategies and they're using compensatory strategies so that they can participate in work, then yeah, they did fully recover. But if we're talking like full recovery, without using strategies and techniques, that's a little bit more tricky. But I have seen in the research that there have been some patients that do make a full recovery. Just in my personal experience, I haven't seen it.
That's the same with me. Nobody who has, I guess, would be completely symptom free. So they're still having dizziness or fatigue, maybe more mild. It is still so early on. And I don't want to say, maybe down the line we'll be able to see people with more recovery, maybe from these later strains. It's really hard to tell, but
yeah,
no, I haven't.
And just keeping in mind too, guys, that this is like a chronic illness. So this is definitely something that they'll be faced with, for the rest of their lives. The ones that do make the full recovery, I think they have reported minimal symptoms of long COVID. Again, but the research is still underway on that.
So with that, have you seen any of these patients possibly have any kind of relapses associated with getting COVID a second or a third time? Does that play any part in the severity of their long COVID symptoms?
Yes. Gabby, didn't MS contract it for a second time during her stay with us?
She did, at least from a physical therapy perspective. Her symptoms weren't any worse, I believe.
Yeah, I think she just had to be out for about a week. Her symptoms of COVID were not as bad as the initial time that she contracted the virus. And then still seeing her a couple of weeks later, we kind of plateaued in terms of progress. I didn't see her get any worse. But I'm also wondering, if this patient contracts COVID once, are we more now susceptible of them contracting it, other times? It's a good question.
No, those are both good insights on it, considering that you guys have had the experience of working with a few individuals. All right, well, we are just about to wrap this up. First of all, I want to thank everyone in attendance for active participation. Great questions. Thank you to both of our presenters. You guys did an amazing job today. Thank you so much for bringing all of your experiences and research and all the wonderful tidbits and anecdotes you have available for everybody. So I'll kind of close this out. Thank you to everyone for joining us. We hope that you join us again for future webinars. And if you have any questions or a patient that you feel would benefit from our partnership, please feel free to reach out. Thank you and have a wonderful day, everybody.